And some of these we've heard about in the earlier panels. Those challenges are not just on the technical side, around privacy, governance, ethics, policy, challenges involving disruptions to status quo in infrastructure, institutions, disruptions in work and skills, and exacerbation of inequities that are already inherent in the system. Nonetheless, there are also huge opportunities for better, faster diagnostics and treatment, research-based improvements in healthcare delivery, and speedier application of new discoveries to improve health outcomes. So today, I'm thrilled to be joined by four esteemed panelists to discuss this issue around winning conditions for scaling digital health innovation. I'm going to introduce them all sort of right off the top, and then we'll invite each to make opening remarks. So first, I'll introduce Dr. Tim Evans. Dr. Evans joined McGill University in September of 2019 as the inaugural director and associate dean of the School of Population and Global Health in the Faculty of Medicine, as well as associate vice principal of global policy and innovation. He joins McGill after a 6-year tenure as a senior director of the Health, Nutrition, and Population Global Practice at the World Bank Group. So it's great to have Tim here. We're also joined by Dr. Robin Tamblyn, who's a professor of medicine, a distinguished James McGill Chair, and a medical scientist at the McGill University Health Center. She's scientific director of the McGill Clinical and Health Informatics Research Group, and was appointed scientific director of the CIHR Institute of Health Services and Policy Research in 2011, and served in this position until her term ended in December of 2018. Dr. Joseph Cafasso is the inaugural Wolfond Chair in Digital Health and lead at eHealth Innovation at the University Health Network. As a biomedical engineer, Dr. Cafasso observes healthcare delivery from the inside out and works on ways to keep people out of the hospital by creating technologies that allow for self-care at home. And finally, Dr. Jane Rylett is Distinguished University Professor at the University of Western Ontario and a scientist at the Robarts Research Institute. She was appointed as Scientific Director of the CIHR Institute of Aging in 2019. She's an expert in age-related changes in brain impacting cognition and other functions, and is recognized internationally for her contributions on neurodegeneration and Alzheimer's disease. So welcome, as I said, four very esteemed panelists. Looking forward to getting some opening remarks. Before we do, just a quick a reminder to the audience that we will be taking questions for discussion. So as you're listening to the opening remarks, if anything occurs to you that you'd like to have discussed by the panelists, you can log into Slido. I believe there's the link there on the screen. The code is RSC2. So feel free to drop any questions into Slido, and we'll be sure to get to them during the discussion. But first, we'll invite our panelists to provide their perspectives on today's topic. What are the winning conditions for scaling digital health innovation? And we'll start with you, Tim. So the floor is yours.
Great. Well, thank you very much, Rob, and thanks to the Royal Society for organizing this day and this panel. And let me begin by suggesting that one of the critical ingredients is a strategic policy for the development of digital health innovation for the country as a whole. And I'm going to draw my remarks on a report that is actually the background that you can see at the moment, which was a process sponsored by CFAR, the Canadian Innovation for Advanced Research, we developed this report called Building a Learning Health System for Canadians, and really it was focused on harnessing the potential of what we called AI for health, but I think very much reflects digital health innovation more broadly. So I'm just going to give a quick synopsis of the key areas, 4 key areas of recommendations emerging from that report in hopes of getting the discussion going. And in the chat, I've just provided people with a link to the report should they want to read it. It's very brief and emerged over a 6 to 8 month process with consultations across the country. But basically, there are 4 priorities that the report recommended. First is the need to set very clear priorities for digital health innovation. And this is just a recognition that there's a convergence of outstanding needs, demands, and opportunities in this space that would benefit from some strategic thinking with respect to priorities. And the task force recommended 3 areas for those priorities. And this is important because people sometimes will just gravitate to one or another area and think that that's the entire universe of digital health innovation. So the 3 areas that we identified as broad buckets for thinking about focus were the first being health service delivery. And those are opportunities to improve efficiency, access, quality, affordability of services. And these translate into things like improvements for patients to take care of themselves at home without having to go to facilities, or in facilities, opportunities to decrease waiting times. The second area was to focus on disease prevention and the broader population health determinants. And these are opportunities really to improve health at its most fundamental level. And, nice example of this in the context of pandemics is the work that Blue Dot has developed in predicting pandemics. And the third area is around discovery and development of new diagnostics, therapeutics, and preventives. And these are also a very important, interesting, exciting area where, for example, in the context of COVID, 10-bit has provided X-ray analysis that's enhanced the detection of COVID-19 pneumonia. For each of these areas, in order for these priorities to be meaningful, there has to be a commensurate development in regulatory capacity. And that relates to the fact that digital health innovation doesn't necessarily fit nicely into old regulatory systems. So what are their criteria for understanding whether or not these things work, whether they provide additional value relative to other opportunities, and what are their guidelines for appropriate use or inappropriate use, and how can that be a regulatory capacity that actually has teeth, recognizing that some of these things are very much in the control of individuals and not institutions. So that's the first area: set priorities and develop the regulatory structure. The second, and this builds on the last panel as much as I got got to listen to it, is really to develop what we call the info structure. Many people believe that Canada would have a comparative advantage in infrastructure given the Canadian Health Act and our universal health system, but we do have a Canadian data paradox, meaning we have universal health, but not universal data or access to it. We also pointed to what we called the streetlight bias in the development of digital innovation. And that's the recognition that a lot of it takes place around data that's easily accessible, around which algorithms can be easily trained. And so when we looked at the skew of digital health of innovation, we found that a lot of it focused on the same data sets around, for example, diagnosis of breast cancer. And in many respects, this is a function of a skew in the availability of data, and therefore is limiting the innovation opportunities. And finally, we were very aware in the task force that in many other countries, there's been considerable development of the data infrastructure through data hubs and other mechanisms. So moving forward, the task force recommended really the accelerated development of the infrastructure with attention to its scope, recognizing there are very many different forms of data, structured, unstructured, simulated data, and how these can be pulled together. Attention to skews, and this is data that are not representative of relevant populations that could be used to characterize those populations. And obviously this is particularly important in this era where there's greater attention to systemic inequities. Third was to develop standards and not only develop those standards related to data quality and reliability, make sure that they're recognized and used. And fourth, understanding different models for data sharing and ownership. There isn't a one-size-fits-all. I think that came very clearly from the last panel, from patient-owned, public, private, not-for-profit data trusts, and federated learning models. These are things where the strengths and weaknesses of these models need to be developed and shared. And last, and very importantly, is the issue of trust and privacy. If we lose trust, then the opportunities for digital health innovation will be squandered disproportionately. So that's the second area, infrastructure. The third relates to financing. And this is a recognition that Canada isn't alone in this space by any means. And we're not the biggest financier in this space. And insofar as we have global markets operating, we need to think very clearly about how we can be smart with our financing in order to compete in global markets. And so there were a number of areas where the task force recommended thinking about ways in which public funds could be used to seed new private capital investments in the startup side of digital health innovation, how current federal support might be tailored more effectively for mid-sized companies in this space so that they can grow and reach into international markets more effectively, how tax incentives might be used, how immigration might be an opportunity to attract talent into Canada, and then a very interesting concept of regulatory sandboxes and how that might bring networks of collaborators together to look at how to create more nurturing environments for digital health innovation. So those were a set of recommendations related to financing. And finally, is the issue of recommendation, and I've left it as last because I think it is the most important, is to recognize that none of this will happen unless we have people. And we're off to a great start with the AI chairs that were created in the last couple of years across the country. But we need to go much further. And we need to go much further because, as I said, in the context of a global market, some of our best assets are very likely to migrate. They will be offered opportunities they cannot refuse. And in many respects, who could blame them? However, if we think, if we're blind to that reality, we won't be prepared to follow through with the breadth and depth of certain cadres that we know are critical. And it's not just the health data scientists and the machine learning depth experts. It's also the recognition that other dimensions of our workforce related to regulation, financing, the media, policy, providers and patients, and the public, most importantly, need to be the focus of some accelerated training efforts. I've left this also for the last because it's an area where, as an educational institution, we have a particular responsibility, and I'm very proud to recognize that work that Robin Tamlin and a colleague of mine, David Buckridge, have been doing has been focusing on creating short course training to really enable people to be more effective engagers and drivers in the digital health innovation era. So just to conclude, we need strategic priorities, a much better infrastructure, smart financing, and a very clear strategy for investing in people that will allow us to harness digital innovation for health and build learning health systems. Thank you very much.
Great. Thanks, Tim. Really great remarks. Lots to dive into there when we get to the discussion, so appreciate that. So up next, we have Robin. The floor is yours. Oh, and you're on mute.
there we go. Sorry, technical challenges. Anyway, thanks very much. Very, very pleased to be part of this panel and to be able to hopefully not provide a rant on what I see as some of the challenges here, but I will contain myself a little bit. So as a previous clinician and a health services and policy researcher, I look at what happens in our Canadian healthcare system and I go, well, okay, we're spending about $260 billion a year on this thing, and we're really not rising to the challenge in so many of the challenging areas that we have, including fragmented care from hospital to home, failing to empower patients and families to sort of manage their conditions and connect with their providers in means other than arriving at the emergency department or in the clinic to wait for 8 hours for an appointment. You see that nowhere greater than in sort of medication management, which has been an area of my interest for quite some time. And I kind of wondered, like, why is it that this is happening? There are certainly, it's not that the technology is not there, but there is a huge gap between the technology that's being developed for healthcare and the actual need in healthcare. So there's a mismatch between where are the pain points, where are the problems, and what are the solutions that we need to create to solve those problems. And so in thinking about, well, who's doing this well, you look at about 2/3 of the literature comes from maybe 5 centers. Maybe it's 6 centers now, but it's a disproportionate amount of the digital innovation that is addressing core issues in actually the delivery of healthcare. Day-to-day delivery of healthcare. So what is it about those centers that makes them different? Why is it that they're able to succeed? And there are key points that I think that we can learn from that, and points that we actually built into funding opportunities to try to solve this problem for Canada. So the first is that, in fact, the people who build the kind of solutions are not very well connected to the healthcare system, which in itself is pretty complex. So there is no sort of meeting of the minds to understand clearly what are the issues, what are the problems, and then how can these solutions, these digital solutions, begin to tackle and solve those problems. So you see people inside the healthcare system trying to develop this, and then you see people outside the healthcare system really not having the connectivity to really understand the problem fairly well. So that's a huge information gap, which can be addressed by training and by modeling, and I'm going to get into examples of that. So when we look at these, these high-performing centers that are producing most of the digital innovation, is they have partnered up with small and medium-sized companies. They have provided a mechanism, a venue, a governance structure that allows them to connect with their clinicians, to connect with their consumers, their patients, so they really understand the problems and are able to actually produce solutions that are meaningful and likely to be successful in solving those problems. So that's been a model that has been tried in Newmarket, Ontario, under the leadership of Dave Williams, a previous Canadian astronaut. It's been set up under the umbrella of Innovation Boulevard, which we can get into in Surrey, BC. And that was the model that we tried to emulate in trying to actually bring these disparate parties together and different funding opportunities together to try to create better solutions for Canadian-based SMEs. The second thing that's a huge challenge is you develop really cool and creative solutions, and then you try to actually commercialize them. So it can't be just in your garage or your backyard, but now you're wanting to commercialize them. And here there are huge barriers to innovative companies trying to bring them into the healthcare system. Highly regulated environment, understandably so, but in fact, it creates huge barriers, and it actually favors essentially large multinational corporations who aren't the innovative thinkers. They buy up the innovator thinker ideas. And so we haven't really created an ecosystem that allows these innovative companies to actually come to play in this field. There are examples here in Canada that we've tried, something called innovation procurement in the federal government, built in my backyard initiatives, but these are few and far between relative to, I'd say, probably what the need is. The third area is that Canada is like 36, 37 million. We're not a big enough market for these companies to survive. And Tim has already alluded to that we actually need to create the right circumstances so these innovators can actually be successful on the international stage. So our biggest market, of course, is to the south, to the US, and that makes sense. But in taking a tour with the National Research Council supports these companies to Europe, in fact, many of them, I'd say very few of them, of the 30 that were there, 2 actually had a market in Canada, and the remaining 28 had markets in Europe and the United States, in the Asian countries, and so they're not seeing an attractive market in Canada. And what we do know about this is you need to facilitate companies not only providing solutions that can work in Canada, but actually test and evaluate and develop those solutions that can work in other bigger markets. And so with that, I'll close off on my initial remarks, and we'll look forward to the other panelists. Thank you.
Excellent. Thank you so much, Robin. Really great perspectives. So next we'll move to Joe to talk about his perspective on the winning conditions for scaling digital health. Joe.
Thanks, Rob. Thanks for having me. It's a great pleasure to be speaking today. So from my perspective, I've been focusing my career on what people call consumer health, patient-facing, maybe more contemporary term is citizen health, more holistically. And I think the reason I fell into this area and I have a passion for it is the impression that the patients here where I'm sitting now at Toronto General years ago in a new pilot program that was created was this concept of home hemodialysis. And I was kind of blown away that patients could be trained to do such an advanced therapy in the home. I thought it was incredible that given the circumstances of a serious chronic illness, what patients were actually capable of doing. And this was back at a time when patients didn't even have access to their personal health information. You know, patient portals were things that were going to start appearing on the scene 5 or 10 years later. So it occurred to me and some of my colleagues that, you know, if we empowered patients with a little bit of data and some self-management tools, they could manage some very serious chronic illness at scale. If in fact, you know, we clearly have seen it demonstrated that patients can do something as like an advanced therapy like dialysis at home with self-cannulation and heparinizing lines and just keeping all the logistics around it. It was absolutely incredible. And over the last 20 years, I've seen it firsthand. I've seen the ability for patients to do incredible self-management through the use of their own information and tools, digital tools for self-management. And I think that, so there's really lots to be proud of in terms of that space. The trouble is the health system is behind the consumer these days. And we're looking to catch up. And I think during the pandemic, there was some great indications of this, is that, I mean, it was a big change for the health system to be moving to virtual care, but it was a bit of a no-brainer for your average citizen. And even though most of it was done by a simple video call, which they're very familiar with, or a phone call, which they're very familiar with, it was quite novel for the health system. And so my concern with the state of digital health as it stands now, not just in this country, but otherwise, it's really just addressing the low-hanging fruit. And really where the opportunity lies is really novel new models of care. And what I would call digital first models of care. And what I mean by a digital first model of care is the notion that the typical interaction or encounter between a clinician and a patient once every 3 months or one every 6 months for follow-up is an antiquated model. And it's really been established for many decades for the purposes for physicians to bill regularly. And if we could create new models of care that are really in real time and exacerbations and patient needs could be addressed immediately rather than waiting to book an appointment or for the regular scheduled visit. I mean, a lot of the for-profit commercial virtual care that's out there now is both innovative and cause for concern. So I'm referring to the Babylons of the world, the Maples of the world, where people can drop $50 and get a family doctor within minutes. It's incredibly convenient, especially for many people in Canada, to have access like that. And I don't really believe that we couldn't achieve that in a publicly funded system either. And I'd hate to think that digital health is being created to exacerbate equity issues in the Canadian health system. But that appears to be what we're seeing in these early days of digital health. what I could see is that if you could decouple the notion of payment and physician reimbursement and access with digital tools that allow for self-monitoring and instant access and a reorganization of the system, there's huge opportunities that we're missing. The things that are going to be facing us is that there will be a level of resistance to automation. And I think that's another big challenge, is that digital health really only works at scale if it's producing high levels of automation that is eliminating some healthcare professionals, or at least reducing the need. And I don't think that's going to be a problem in Canada, because the demand will always outstrip the needs of the system. So I look at it as a huge opportunity that there's certain tasks in the system that are fully automated. And this will need the citizens to adjust as well, because they'll have to get used to having an algorithm respond to them, perhaps, rather than a real live person. But at least they're going to get access quicker and more timely, and hopefully that'll achieve a better outcome for them. And I hope it also eliminates what we've also noticed during the pandemic, is a lot of low-value care. And what I mean by low-value care is that I think we experienced it in our own system, is that, although there were some shocking results of the pandemic when outpatient clinics were closed down and referrals slowed down at our cancer center, and certainly we're seeing the consequences of that, in that people are presenting with late-stage cancers. So that was a concern. But on the other hand, there was a lot of low-value care that nobody missed, but was there. And we put in systems and virtual care systems for the physicians to be able to bill for that low-value care. So I think if we look at digital health as an opportunity to recast the health system in a digital-first model, eliminating low-value care, being more responsive, I think there's some great opportunities. The one other thing I want to talk about before I pass it back is the access to personal health information. There's been an explosion of patient portals and improved access to personal health information in the last 20 years in Canada. But it's still, the model is still the provider remains the custodian of the data. And we're allowing patients to have access to their personal health information, which is a step in the right direction, obviously. But we're at the point now on the technology curve that it's not actually necessary for custodians or care providers to be the custodians of personal health information. The technology is robust now. So there's enough ubiquitous in the technology in the consumer realm that patients could be the custodians of their own data. And in fact, will be ideally suited to aggregate data from multiple sources, which ourselves as providers have great challenge aggregating that data for privacy, security reasons, data sharing reasons. So if you view the patient as the custodian of their own data, that they can aggregate their own data, then they can share their data as well. Or more importantly, I think the term needs to change to the notion of them donating their data for research purposes, and ultimately for provision of care. So I think there's a policy opportunity there to start viewing the citizen as the custodian, aggregator, and donator of their own data, rather than leaving it to the system. Thanks.
That's great. Thanks, Joe. Really stimulating ideas there. Look forward to coming back to them. Okay, so finally, our last panelist, really interesting perspective on this question around winning conditions for digital health. Jane, the floor is yours.
Okay, thank you, Rob, and thank you to the Royal Society for organizing this really very interesting day. I'm going to focus on the challenges and opportunities in digital health for older adults specifically. So this is a critical topic for a large population of individuals that have unique vulnerabilities, particularly health vulnerabilities. And this has been evolving very rapidly over the last number of months, obviously, due to the impact of the current pandemic. So Canada is undergoing a large change in population demographics. If you look now, there are more adults aged 65 and older than there are children 14 and under. By the year 2025, 21% of our population will be over the age of 65. More people are living longer and want to stay healthy longer, live independently, and participate fully in life. But we also need to consider that the inherent decline that's associated with aging can limit the full engagement over time. So supportive strategies need to be developed to ensure good quality of life. In terms of health specifically, by the age of 65, 1/3 of individuals have at least 3 chronic conditions. And then if you move along the age spectrum, by age 80, now 2/3 of individuals have at least 3 chronic conditions. This signals a huge increase in need for healthcare, specifically, obviously, but also an increase in digital health needs for our aging population. So in terms of digital health, many of the needs of older adults are really similar to the needs of other age groups in our society. But older adults may need greater access to remote healthcare, for example, with increased virtual visits to healthcare providers and physicians. Also, healthcare providers need to be able to collect more precise and timely data on the complexity of health and well-being of their older patients. There's a need to create technologies and scale digital health for older individuals, but it needs to be taken into consideration that this is a very heterogeneous group of individuals, and it's stratified by age, obviously, change over a few decades. So the younger older adults, for example, are probably fairly comfortable with digital solutions, but when you start advancing to the older age groups, the more advanced ages, they're probably less likely to use technology, and this can lead to systematic exclusion of individuals, particularly those with age-related physical and cognitive changes, such as changes in vision, hearing, mobility, and memory. So we need to be mindful of the digital divide, gaps in accessing technology that can lead to societal inequities. And I think that individuals in the aging population, particularly those in the older age groups, particularly really run the risk of being excluded at this point. So there's need to develop targeted training for older adults to ensure that they're able to access and understand their own personal health data. Also, for older adults that have a much higher need of care, their caregivers will increasingly need access to health data solutions on their behalf. So examples here would be individuals with dementia, so there need to be solutions developed for caregivers so that they can actually access and mediate on the part of the ones that they're caring for. So looking to the future, what are the opportunities and challenges to optimize digital health for older adults? Well, if we look worldwide, the older adult population is already at a historical level of over 600 million people. This is projected to hit 1 billion by the year 2030 and 1.6 billion older adults by the year 2050. And a staggering number is that 30% of Canadians will be age 60 or older by the year 2035. And at that point, we become one of the world's few super-aged countries. Healthy aging is already a contemporary challenge, with digital health interventions having the potential to support and empower and engage older individuals. But when scaling digital health innovations, this is not a one-size-fits-all solution. Older adults need targeted solutions that take their complex abilities and health needs into consideration. Digital health innovation should be designed with the involvement of older adults from the start, not just at the end of the innovation process. There's an increased need for high-tech wearables that monitor everything from blood pressure to daily step counts, from screen magnification to talk to text, and even assistive home automation to help older adults continue to live independently and safely and maintain good health. So we need to look at Canada as a place where we have a highly aging population, but we also need to look outside of Canada. We need to look internationally for ways in which we can engage on this. So for example, G7 countries could come together on common research initiatives to improve digital health scaling to meet the needs of older adults across the world. This could include exploring evidence-based health interventions, methods for implementation, and effective delivery. And just as a last point, at the moment, Canada participates in a European initiative called IDIH. This is the International Digital Health Cooperation for preventative, integrated, independent, and inclusive living. And along with Canada, there are 4 EU countries involved. The US, South Korea, Japan, and China are also involved. And the aim is to promote and increase international research collaborations to advance digital health, to support active and healthy aging through innovation. So I'll stop there, and I look forward to engaging in the discussion.
That's great. Thank you for those remarks, Jane. Thank you to all the panelists. A lot of thought-provoking topics that will surely generate more interesting discussion as we move into this part of the panel. Just a reminder, as people can see up on the screen here, we do have a Slido set up for people to submit questions. If there's anything you want to address or would like to dive in on a little deeper, it's there on the screen. You can go to Slido, and the conference code is RSC2. So I'm going to get things started off, though, and I actually want to pick up, Jane, a little bit on the last kind of remarks you were making there around kind of international connections, international perspectives. And just to say, this is, a discussion around, that was sort of launched by the G7 Science Academies. So, internationally, countries around the world are struggling with digital health as the challenges and the opportunities. A lot of what we've been talking about today strikes me as being, somewhat Canadian focused. I'm wondering if we could maybe open that up a little bit to describe, what's happening in some of the other countries that maybe provide good examples, where there's some leadership that we can learn from, lessons we can draw from, and so on. Maybe provide us a bit of perspective for tackling things at home. And I would like to get everyone's perspective. But Tim, I'm thinking, especially given the perch you had for several years, kind of working in that international space, that you might want to kick off with giving a bit of your perspective with maybe where other countries are leading the way for us.
Yeah, thanks, Rob, and I'm delighted that you brought this up because I think the digital health era that we're moving into is one that really defies traditional jurisdictional boundaries, as much as those are very important to recognize with respect to issues of proper use of data. But at least my experience is that things are moving very, very quickly. So let me just give you a couple examples of this and with reference to why thinking globally on this is so important for Canada. Rwanda, middle-income country in the middle of Africa, has developed a drone delivery system for essential blood products. These drones are programmed to fly from 2 drone ports to district hospitals and deliver blood products, the specifics of which are emailed into the drone port. And so around a blood bank at the drone port, they can type and match and send the blood products back. They get them there within an hour, and you have all of a sudden transformed the supply chain and the delivery system in a way that would have taken years through other what I would call 20th century modalities of managing the supply chain. Of course, a drone delivery is not limited to blood products, and in remote areas where you need to get things quickly in good shape to individuals or institutional settings where people get care, tremendous opportunity. They're not waiting for anybody to give them permission. They see this as an opportunity and are pursuing. Another example, China, as we know, massively invested in digital health solutions. Again, they see this as an area of global competitiveness, and obviously one where as big as the market is in China, 7 billion is a lot more interesting than 1.4 billion. And so they're moving this agenda very, very quickly. And I think one of the really important things, Robin said, our market to the south is incredibly important. But one of my reflections is that virtually every part of the OECD countries, the rich countries in the world, innovators in those countries focus on the US market because that's where margins are largest. But volume is not very big. And so often as we were looking at the development of the markets, we would say, why not go after lower margins, but where volume is actually much greater? And then when you made that value proposition to people involved in digital health innovation, they could see that. And so I think understanding that this is truly a global market, not simply a market which is going to cater to the US health system or dimensions of the US health system, I think is going to be the way forward. And I would hope that Canada really tries to embrace that. I'll stop there.
Excellent. Really interesting perspectives. Thanks, Tim. Robin, how about you? You talked a little bit about the gap, the mismatch between, sort of solutions and pain points. Do you think there are jurisdictions that have got this figured out that we could learn from?
Well, there are a number of jurisdictions that are interesting. I don't know if we could say anybody's come up with a perfect model. So Finland, for example, is a country that has really got its act together in trying to facilitate the funding and support for what I call innovation hubs. So they've set up partnerships between academic health centers, small, medium-sized businesses, an ecosystem of bigger businesses, and consumers and clinicians so that they can actually start developing solutions that will work. And I think they've got that model, close to perfected because they are coming up with some very interesting solutions. Germany basically has just stepped into the gap here to say, listen, you have a solution that will improve the value and cost effectiveness of healthcare through a digital innovation. We will pay for it in our health system. Well, that's a big item, big item. Because I think whether or not is the payment of how healthcare is paid for will either drive or smother innovation. And so these countries have played around with those on the margin. The Center for Medicare Medicaid has said, okay, we'll pay for you paying attention to patient monitoring information, so that we'll pay for that. If you start paying for outcomes achieved, then that's a very different driver than number of beds occupied. So outcomes achieved means I want to go for the best, most efficient, best outcome model. And there you will see a big pull, I have to say, for digital innovations. So if you look at one of the centers that everybody flocks to from around the world, it's Kaiser Permanente. 50% of their visits are televisits, essentially. They have a lot of other bells and whistles that are there to improve outcomes, very creative thinking, but that's because they're very outcome driven, and that's they're in that pay for performance group that's or whatever accountable care organizations that essentially are driven by that. So I think we have a number of things that we could cherry pick around the world to actually say, here are some important drivers that we need to think of in terms of our policy framework and environment. Just the last comment I'd like to make is that when you're faced with challenges, and I like Tim's example of Rwanda, but probably the most interesting innovations have occurred in the lower middle income countries in terms of mobile health solutions that take advantage of the fact that you don't have a wired infrastructure, but you can actually use satellite technology and you can actually overcome many of the barriers. So some of the innovations are occurring in the lower middle income countries. And if we could just adopt those to deal with some of our rural, remote, and other challenges in Canada, wow, I think that would be very exciting.
Yeah, super interesting. Thanks, Robin. How about you, Joe? Do you want to tackle this issue? I mean, you sort of touched on some of the quirks of the Canadian system, source of great pride for many Canadians, but also a source of frustration, particularly when it comes to that kind of consumer interface. Are there examples that we could actually think about adopting here in Canada?
Yeah, I mean, I kind of have three things in mind. Obviously, the U.S., because of the profit motive and a lot of capital and speculation and 18% of GDP spent, there's lots happening down there. There's lots of innovation. There are some very good digital health, digital therapeutics companies that are on the NASDAQ now and are raising even more capital. Not all of them are going to be successful, but they are testing this notion of a new model of care, digital models of care that are just in time, that have elements of self-management and data, and the most appropriate care provider at the most appropriate time. So they're experimenting with all those things. but it's for a profit motive that won't translate well into the Canadian market. But that doesn't mean we couldn't adopt similar thinking in our own system. And so the idea of adopting U.S. technology into the Canadian system with the U.S. business models is not going to necessarily work. Having said that, again, we can learn a lot from those new models of care, what's successful, what's not successful, and adapt them in our publicly funded system here. The one thing I also noticed in the Scandinavian countries, and I've spent quite a bit of time in Norway, is that Norway promotes and uses their own technology. Their EMR, EHR systems are Norway designed, built, tested, and scaled. They use their own technology for a country of only about 5 million people. They're very innovative in the digital health space, and they adopt Norwegian technology. That doesn't happen as often in Canada as much as I'd like. A lot of Canadian companies need to prove themselves elsewhere before coming back and seeing adoption here. So I'm not sure if it's a necessarily policy in Norway or whether it's nationalistic pride or what it is, but they often export far less, or rather they import far less than they use internally to their own systems. Now, with respect to low and middle income countries, we do have projects running in Africa, and in particular, I'm often amazed at what we can see in terms of innovation in places like East Africa, and in particular in Uganda. What we saw in trying to adapt some technology that we developed here in Canada is that obviously it's not necessarily going to translate well into a health system of 48 million in Uganda, where most people don't have smartphones. But they do actually have more mobile phones than they have people there. And they use technologies that the most North Americans would be very unfamiliar with. They use mobile money as a means of data of transactions and data transfer. And there have been some great examples with UNICEF and pediatric and obstetric care using a mobile money system for algorithmically driven chronic disease management. And we're just starting an NIH-funded project in Uganda. And if it wasn't for the innovation of using such a simple, ubiquitous technology, such as the mobile money system, the USSD system more technically, we would never be able to get it off the ground. But that's something that will scale very easily in a country like Uganda, where there are, again, more cell phones than there are people.
Wow, that's great. Really, really interesting. Thanks, Joe. And then Jane, I want to give you an opportunity to weigh in on this question too. You mentioned at the end of your remarks that the need for us to kind of work across borders, but you also flagged that we are an aging population. Are there things that we can learn from countries who are a little further along that curve that we would want to take into account?
Yeah, that's a great question, Rob. Japan, obviously. Japan is at the moment, the only super aged country in the world. They've led this by a few years. We're not far behind. By about 2030, 2040, there'll probably be at least a dozen countries, and we will have been there for a few years. So I think when we come to looking at the question of how Japan is managing this, I mean, they've got a lot of automation, wearables, these sorts of ways of digitizing information that they can gather on individuals. How they manage that information, I'm not sure, but they are a model to be able to look at in terms of automation for assistive devices for older adults moving forward. Israel also actually is a leader in this area, along with the Scandinavian countries, and we've already heard about them.
Super interesting. Okay, so Japan, Norway, Rwanda. It feels like we've got, we're all over the world, places that we can learn from, which is really great. Okay, so I want to shift gears a little bit. So we're thinking about the winning conditions. Panels earlier in the day have touched on some of the, kind of the non-technical elements of digital health, ethics, and privacy and governance. Things we've been discussing here that have come up are issues around, kind of regulatory approval, kind of a billing incentives, market uptake. So a lot of non-technical areas that are tricky, right? So I wonder, what are the questions that we should be asking now, today, the conversations we should be starting today, in order to lay the foundations for future, progress in digital health? Where would you actually start those conversations if you could today to have a big impact? And here, I'll open up to whoever wants to jump in on this next question.
So I can just have one comment. And
sure, thanks, Robin. So
I think COVID, for example, is a game changer. We're going to look at things in a different way than we ever have before. But the one thing that's lagged behind is the way in which we pay for our healthcare system in Canada. So we're paying on a service by service basis. Or a bed occupied by bed occupied. We have to come up with experiments, can't go whole hog on this, where we're using a different framework to pay. And of course, the previous panel was very helpful because they're talking about the access to the data that will allow you to start paying by quality and paying by outcome, adjusted for case mix. I think that to me will be the big driver. At least it will be one very important piece of the driver, because right now it's the inhibitor of innovation, as I would say. You're paid for doing the same old way, as Joe points out, low value healthcare in some instances. So that to me is a very important part of the game changer, is to have experiments in policy change.
Excellent. Thank you. And someone's got delivery showing up, so feel free to run off and grab your package. Anyone else want to weigh in on this question about what are the conditions we need?
Yeah, I think I'll just mention the area of harmonization. I mean, this is a topic that seems to come up in every panel, obviously, but data harmonization, whether it's data harmonization across local jurisdictions and hospitals, data harmonization and healthcare areas, data harmonization across provinces, across the country, or internationally. It seems to be a huge inhibitor to be able to move forward with a lot of work. And it also probably costs a lot more money in the long run than we're able to save in the process. So being able to come up with mechanisms and, in fact, legislation, probably, when you come across provincial jurisdictions, to be able to accomplish this.
Excellent. Tim?
Rob, yeah, just excellent comments. I think Robin's comment of purchasing for value instead of volume is a really important financing shift, which is overdue in a lot of tax-based and social health insurance-based systems. But the other area that I think I want to point to is two areas. One, I think we have to, and I'm saying this being a newbie back in Canada, and so this will sound heretical, but I think we have to really challenge the federal-provincial relationship with respect to financing the system. At the moment, it seems to me to be more a barter process and negotiation to get more, but without any real accountability in terms of performance. And if I look at COVID, the provinces have had a lot of money from the federal government, but if you look at the performance, for example, in one domain, testing systems, it's hard to really see how money has improved testing in any significant way, particularly in the biggest and wealthiest provinces. And so I don't think that sort of performance should be encouraged. I think it should be, we should have an incentive formula with clear standards, measurable benchmarks. And I think that accountability to Canadian citizens who are footing the bill is fundamental. Now, I know that's heresy, but I'm using my excuse of being a relative newbie on the landscape to use it. The last thing I'd say on this, I think we have to look, and I'm saying this now as an educator, I think we need to train our future workforce, and this is not just clinicians, this is people who are going to be engaged in the health sector, to understand that one of the primary areas of competencies that they need to show a proficiency is in the area of change management. And not simply depth competencies in technical areas, but that they understand that they're agents of change in the system and they need to take risks to make the system work better. And I think if we permeated that culture in terms of real competencies of our curriculum, and then fostered that in terms of the institutional settings that people work, I think we'd be amazed at the brilliant ideas that come up and are generated because they're given more recognition as being a critical part of training. Over.
Awesome. Thanks, Tim. Joe, did you want to get on this?
Yeah, on the finance aspects is that, you know, you all know that we have a lot of sort of misaligned incentives in the health system. And in particular, I think around digital health, it wasn't that long ago, pre-pandemic, that in fact there were, you know, provinces were paying premiums for physicians to adopt digital health. They got an extra fee code if they did things online instead of in person, which to me was ridiculous, quite frankly, is to have an extra financial incentive to the adoption of digital health. You know, many provinces in order to allow the adoption of electronic medical records in primary care also had incentives. And other jurisdictions did the same as well. In the US, the ONC had incentives, but they also have penalties. And in Canada, I think we like using the carrot, but we often don't want to use the stick in the levers that the provinces and the federal government have in terms of managing the use of resources and in particular digital health. I think one example is that in the US, CMS was trying to do something significant about the awful rates of readmissions in some hospitals, and you know, in a for-profit system, for-profit hospitals, in fact, readmissions actually are a good thing from a bottom line perspective in the US. So the CMS just wouldn't put up with readmissions and would penalize hospitals for readmissions. That doesn't happen in Canada. There's really few reasons to eliminate readmissions other than it's good for the patient, but they're often, because of the demands on our health system, they're just simply going to be replaced by more and more patients. In the US, they used adopted technology in order to prevent readmissions, but in Canada, there's not a strong incentive for a jurisdiction to do that. And if it rolls up to the provincial level, there are incentives to do that in terms of better care management and costs. But at an individual level, on a hospital by hospital basis, there are fewer incentives for doing that. I'm not suggesting that we should use the stick instead of the carrot. But again, we need to start aligning incentives, and maybe it is value-based care that we've been talking about that is ultimately the direction that we need to go in.
Okay, excellent, thanks. So since Tim has suggested we reopen the Constitution with regards to, we might as well tackle all the issues, right? So funding, federal, provincial funding is, a complex and what seems to be maybe inefficient kind of mechanism to get the outcomes we want. But of course, the jurisdictional issues extend beyond this. Provincial, health is provincial jurisdiction, and so health data ends up being held, at the provincial level. And certainly our experience at Genome Canada, even with the COVID crisis, we have had to come face to face with the challenges of sharing data across provincial boundaries and so on. And that's a perpetual story in Canadian healthcare when we're looking to do things beyond the provincial level. So I'm wondering, from your perspectives, is this an insurmountable problem? Do we have to ask Tim to go in and change the Constitution for us? Or, are there examples or workarounds that are out there that we can foresee where we can work within that system to actually build the sorts of kind of cross-provincial border health solutions we might want? So again, I'll open this to whoever might want to tackle that first.
I just want to provide one example. There was an example of this, exactly what Tim was talking about, which was over the wait times for certain procedures, in particular, hips, cardiac surgery, and so on. And so in the transfer payments, there were conditions, supplements provided, but conditions that, in fact, there would be accountable reporting back on the actual wait times. And in many provinces, that led to putting in place systems that would allow wait times to be monitored and actively managed. And so I think we have had an example of that being a success in Canada, and it might be a way to move. I think it's a way to move within the our current Constitution. One thing that I think has to change is that in the health system itself, there is not deep capability to actually analyze and manage the data. There's data galore, but there's the governance issue, of course, but the talent set needed to actually take that data and turn it into meaningful metrics, I'd say, is pretty 1960-ish. And I think that's where we're going to have a challenge, and that's where we need to actually build expertise, capacity within the healthcare system and the ministries of health to do that, and to make use of the abundant data that we actually have in digital form to actually inform and benchmark performance as we go.
Yeah, excellent. Thanks, Robin. Jane?
Yeah, another area where certainly there may be able to be change affected, but without opening the Constitution again, is in the area of long-term care. So we all know of the devastation in long-term care early on in the COVID pandemic, with something like 80% of the deaths in the country were older adults, to be sure, but the vast majority of them were in long-term care. And in fact, Canada has the worst record around the world on this. So one of the problems, of course, is that there is no federal oversight of long-term care. It's all at the provincial level, managed very well in many provinces, but it's not interoperable between the provinces. And things like training, for example, can be vastly different across provinces. Certainly the workforce, even the names of the care assistants in long-term care homes are different across provinces. Orderlies in Quebec, personal support workers in Ontario, and it goes across the country. So, and the governance model is at the provincial level. Certainly from the throne speech from the throne last month, long-term care and retirement homes, and indeed the issue of federal versus provincial and territorial governance models in this was raised. So I suspect that this will be an area that we're going to see change in the coming years, hopefully in the coming months indeed. And this will then start to redress for the issues that have existed over decades, actually, within this sector. And many white papers, many panels commissioned around this, but no real resolution. So this is probably an area where we can see change. Certainly, data management within this sector needs to be completely overhauled, and probably won't involve opening the Constitution.
Yeah, that's good news. Anyone else want to weigh in on Tim, do you want to weigh in on this?
As a constitutional expert, I can guarantee you that I would make an even greater mess. So I think one has to be careful about picking your battles on this front. And I think sometimes around focused, discrete challenges, there's more of an opportunity, especially if there's a crisis, to generate some consensus and understand the scale efficiency opportunities of getting our FPT islands better bridged. I do think on COVID-19, in addition to long-term care, on vaccine surveillance, which is going to be upon us imminently, thinking about how we federate that, recognizing that the scale that needed to understand some of the safety issues is something that is unlikely to be achieved in any provincial jurisdiction on their own, or less likely to be achieved. So I think that might be one opportunity for perhaps breaking through and making some progress on that front. I do think another dimension which Joe mentioned earlier, which I thought was a brilliant idea, was moving towards patients owning their own data. And I think that's important because, in a sense, it makes this less a singular provincial jurisdictional or an institutional issue, and accommodates what I think is a greater reality of Canada, which is patients and the public move across jurisdictions. And that portability, I think, is going to be increasingly important for continuity of care. So I'm just giving I thought Joe's earlier comment was really perhaps one of those areas where you could have breakthrough if there was some consensus that patients or the public should be stewards of their own data to a much larger degree.
Yeah, that's great. There's a couple of questions on Slido. One related, that's kind of a follow on here, that COVID has accelerated, and Joe mentioned this earlier on, a certain amount of kind of remote care, at a distance care, often even within urban environments, but that can be hopefully, kind of transported into dealing with kind of rural and northern communities and so on. Is there any effort that any of you are aware of to, in a sense, sort of address these provincial issues with regards to this kind of remote care? Because this kind of gets to the scaling issue, Tim, that you're referring to in a few other areas, right? That individually it's difficult for provinces to build at scale for what might be a small population, but nationally, kind of remote care tools being rolled out for rural communities would make a lot more sense. Is anyone familiar with anything like that going on when it comes to, say, telehealth or other kind of rural delivery mechanisms?
Yeah, well, it still falls along provincial lines typically. So Canada Health Infoway has financed a lot of initiatives at the provincial level, and most of their funding was depending on provincial matching. So it typically falls along the provincial lines. And a great example in Ontario is that OTN has rolled out a number of remote monitoring initiatives over the years, backed by Canada Health Infoway funds. So ultimately, there's still the pattern that although it's federally funded, it's provincially delivered. I'm sort of unaware of anything that's cross borders in the remote patient monitoring realm.
Okay, that's helpful. Thanks. One other question that's on the Slido here that I'm going to come back to you again here, Joe, actually, is a bit more of a technical question, and this has to do with APIs. And as somebody who's not a computer guy, my understanding of APIs is that they're the interface between different systems that allow them to speak with each other. And so the question really is around, in a sense, the role that APIs play as we think about scaling up, as we think about future innovation. Are there challenges involved here? Is this a scalable kind of issue, or is this going to pose a problem going forward?
Yeah, so it's a great question, and there's been a lot of innovation in the portability, the interoperability aspects of health information in the last 5 years, let's say. A modernization, more contemporary methods of data portability. And it's my opinion that there are no technical obstacles for health information portability. Really, the problem is there are policy issues, quite frankly, legacy policy issues around data portability. And the other thing that's unfortunately rearing its ugly head is business practices. So from a business perspective, a company that holds personal health information, it's not in their interest to have that data to be portable, because if the data is abstracted and portable, you can be the interfacing part, the clinician facing or the patient component can be easily replaced. So extracting data away from the presentation layer is always a bit of a challenge, because companies don't want themselves to be removed from the equation. They don't want third parties to get in the way between them and their customer. And so, you know, the business practices that I've seen are quite disturbing. So, I mean, you know, anyone who's been in research, they've probably been faced with situations where they have to pay to get access to their own data within electronic health records. Patients often have to go into proprietary systems to get their diabetes data. Why? Because businesses are realizing that the data is as valuable, or perhaps in the long term, more valuable than their products themselves. Having access to the data in the age of machine learning and AI and algorithms, having access to that, their customers' data is extremely valuable. So this is something that we're going to be faced with. And the only thing I can say is leveraging our buying power to prevent companies from doing this. I know that this is working its way through provinces now in terms of the practices, but we're never going to get full data portability if they're being held hostage by IT companies.
Yeah, if I can just add to that, because I think we've had a recent example of this being a huge problem, and that is that the companies that are involved with extracting data from systems in the US, it cannot be the same companies that are holding the data. So there is a separation of this kind of, I'd say, major conflict of interest. We do not have that in Canada, and there was a recent incident where, in fact, the cost of extracting data from EMRs, which have been used for quality monitoring and surveillance, in fact, was more than quadrupled in price, because there was basically a monopoly on who owned the EMRs and so on. And there was this failure to separate the roles between companies that can extract data and are responsible for that, and companies that basically possess the data as part and parcel of their software systems. I think it's a huge issue, which will get us into a real snaggle if we don't deal with it at a policy level.
Yeah, and just to follow up on that, it's clearly simpler to do the extraction of data from a system. Trying to generate data, transform it, and reinsert it back into the system to display to the clinician is often restricted. So even though there's some semblance of interoperability, you often come across with these larger companies restrictions on what can be reintegrated back into the clinician or the patient experience. So, I mean, there's all kinds of business tactics to keep you paying. Often, I mean, I think those practices need to be relaxed or reviewed, and in some instances, again, from a policy perspective, shut down.
Rob, I think the public-private interface on APIs is extremely important, as Joe and Robin have identified. I'd like to just shift your question a little bit, though, to look at some scale opportunities that I think APIs will facilitate, and perhaps relevant in the current context. So, for example, we've been with the COVID-19 Immunity Task Force, where we've got working with a lot of partners who've got deep data on genomics, which relate to virus and host. And then we have a growing set of data on immunogenics or immunotyping. Together with the European Bioinformatics Institute, we've been looking at not only bringing those data together, but also linking them to population level data. And so I think this opportunity of getting different levels of data together in pools that allow insights on distribution and diversity that many smaller jurisdictions would be unable to achieve, is perhaps an opportunity. So in the context of moving forward to digital health innovation, perhaps one suggestion is we think about 5 priority areas where building an infrastructure through innovative APIs around specific types of problems, which are not only national, but shared with perhaps some international partners, could be ways where you create those data pools which enable a much more powerful and meaningful assessment that anyone could get on their own. And then that's stewarded in such a way that it has a more appropriate interface with private sector partners who could develop applications associated with that data, but respect some of the data propriety and integrity issues that would be associated with more public trust. So it's just a suggestion that we're seeing this emerge in the context of COVID. And that may be one of the silver linings that we try and extend to some other key axes of focus that health systems are struggling or need to focus on moving forward.
Yeah, that's great. Good observation, Tim, and one that aligns certainly with our experience at Genome Canada as well. Sort of it gets around some of the challenges with this federal, provincial, jurisdictional issues and international boundaries, where if the data can stay where it already is, but you're able to build the necessary linkages to do the analysis and so on, it allows you a lot of flexibility without having to then confront these issues around data portability and so on. So a good observation. So we're coming towards the end here. We've got about 10 or 12 minutes or so left. And so I wouldn't mind coming to kind of looking outwards to the future here. This is about, creating the winning conditions for digital health innovation going forward. I know 2020 has been a heck of a year, but I want us to put on our optimistic hats, to think about, the potential that's out there. Certainly we've talked a lot about the challenges, but if we could, say look ahead 10 years down the road, what are the kind of most likely ways, if we can start getting some of these things right, what are the most likely ways we see digital innovation in the health space impacting our lives? And perhaps we'll go around, but we'll go in reverse order from the opening. So Jane, do you want to maybe kick us off with where you see things 10 years from now?
Yeah, okay, Rob. I think that's a great question, and it's really fun to think about as well. I think when I look forward, I think the idea that Joe has put forward about individuals owning their own data, I think is absolutely critical. And then the point about how that data is accumulated, how it is acquired by the individual. So being able to acquire the platforms that are needed to be able to acquire the data, whether it's through wearables, whether it's through other sorts of automation or other sorts of interfaces that can allow us to be able to acquire our own health data, then to be able to access that data and to be able to have interpretation of what that is, to be able to then be able to participate very effectively in informed decisions around health. So if the Canadian population was educated at a level that they could do that, then I think that would actually move us forward from the kind of dependency type of situation we may be in now in many situations, to be able to be more responsible and more informed about our own health.
Awesome. Thanks for that, Jane. How about you, Joe? Looking ahead, where do you see things 10 years from now?
Yeah, I think I'd like to see Canada eat its own dog food. That's one thing in terms of supporting Canadian technologies. Instead of waiting for them to be externally validated and brought back. That's one thing I'd like to see. The other thing I would see is that I'd like to see patient portals be something of the past, really. I think at last count, Ontario had 70 different patient portals. And can you imagine the Ontario citizen who has 6 different patient portals and it's really quite a reflection of our health system, right? siloing of care, the siloing of health information, and now the siloing of patient portals, very reflective of the governance of the health system. So maybe we can innovate in that space and allow the individual to be the aggregator of their own data, be able to share it, be able to donate it for research purposes. I think that's really something to aspire to. And then finally, I think from an innovator's perspective, Canada is a powerhouse in terms of AI, in terms of digital health. And I think we need to be pursuing the more advanced digital therapeutics, not the low-hanging fruit, not just layering digital health on top of the existing traditional system, but really looking at those new models of care. And I think those ideas could be exported to other countries. And so I encourage that they're going to need some receptors in Canada in order to make that happen.
Awesome. Okay, thanks a lot, Joe. And Robin, how about you? Looking ahead 10 years.
Yeah, so looking ahead, first of all, I think that Canada, since the Romano report, Kirby report, named the report of what advised on the future direction we should be taking healthcare, and basically it's amazing how little movement we've made. And I do think that the game changer here has been the pandemic, and that I am hopeful that this will be the pivot point where we can actually engage. We've had to engage in doing things very differently. So this is great. Moving towards a value-based rather than volume-based healthcare system, I think, is absolutely essential. In order to do that, we have to start aligning the federal investment in the digital infrastructure, which is Canada Health Infoway, because that's really been on technological, I would say, current stage or future stage platforms to, things that will deliver that value. What's essential to deliver that value? And there you need the consumer input, you need the clinician input in order to say, where are the pain points? Where do we need to see the value happening? So we put in all of these things like pharma nets and lab nets so that we don't have this redundant testing, and then we prevent anybody from accessing that data. So just an example of, not really aligning things together. I think the second is that we really need to ramp up the training of people who know how to use and turn the data around to actually produce valued and important feedback. And then the third is, I think we need to embrace this new aging digital whatever person group that basically is going to, I'd say, be quicker off the mark in adopting new digital technologies, especially if it can prevent them from waiting for 8 hours in the emergency department. This is a huge motivator to improve access for this population, which really avoids these places now because of their concern about COVID. And I think the last issue is very careful attention to avoiding the increase in potential disequities in access, in capacity to use digital technologies. And I was impressed with the United Kingdom in their approach to this when all schooling went online, and they realized that, the poorest families don't have an internet, they don't have computers, and they basically provided these as a state policy so that it would equal the playing field. That's the kind of thing I think we need to be very conscious of when we move forward on this, is that we leave no one behind, and that we particularly deal with a group of people who have already demonstrated that they have poorer health outcomes, that they have inequitable access to care. Thanks for the opportunity to comment.
Excellent. Thanks a lot, Robin. And Tim, for you, looking ahead, what do you see?
Well, I think by 2030, if that's 10 years ahead, we'll be nearing the end of the first round of discussions on renegotiating constitutional arrangements on health. So that's the wisdom of my earlier discussion proposal. But assuming that we don't get bogged down in interminable politics, I would like to see a couple of things. First, just building on Joe's that comment, I'd like to see a clear strategy, economic strategy for Canada, which positions digital health innovation centrally as critical to our growth as an economy. and virtuous growth, because I think this could be something which is not only good for Canada's health, it's good for Canada's industry in this area, and I see this as massively, has a big upside. Very closely linked to that, I'd like to see Canadian companies leading not only within Canada, but globally on the development and of discrete areas of digital innovation, which relate to either delivery, managing determinants of health, or in the area of discovery and development of diagnostics and therapeutics. So I think that's a second one. Under some of the big ideas that I think could be transformative, I think if we took and looked at ways in which we can bring data together across different levels, from the omics to what I would call the emics, the pandemics, the syndemics, the systemics, then that would be revolutionary and define our competitive asset in understanding and better catering to the complex nature of the health problems that we're facing. And lastly, I'd like to see our Canadian universities become the world's best at training for digital health innovation with a global perspective. And I say this both as initially in the context of people being the primary drivers, but that we pay attention to the diverse disciplines that are going to be critical to stewarding this, and that we challenge our curricular offerings to bake in collaborative leadership, change agent competencies everywhere, because we're not only trained to understand depth, we're trained to problem solve. And the better and more entrepreneurial and effective we can become at finding out new ways to break through and create value, then I think we're going to be much more successful in catering to our own population's needs, but also positioning ourselves globally in an area which I think is going to be increasingly important as we move towards 2030.
Excellent. Thanks a lot for that, Tim, and thanks to all the panelists. What a discussion. For me, a couple of the themes I was jotting down here, right, what came through over and over again was thinking about value-based and not just service-based, clearly a big issue, and thinking about the right incentives around policy, regulation, some of these other kind of systemic issue conditions for innovators and innovation, kind of having risk, but also recognizing the economic potential and building that into the system. And then thinking a lot about the vulnerable populations. And Jane talked about our aging population, but other issues around equity and access, I think clearly came through as well. So lots of challenges. Also, a lot of opportunities. It's easy, and maybe it's a Canadian thing, to kind of get caught up in what still is yet to be done. A quick anecdote, my background is in basic research, and the first time I really kind of started interacting with kind of where the rubber hits the road in terms of health, kind of healthcare, health integration. I was in a meeting where people talked about, kind of facts-based care, and I was thinking, well, of course it's facts-based, evidence-based. You need to have facts and evidence, but they meant fax machine-based, and I thought, oh my goodness, are you kidding? But so even since then, we've come a long way beyond fax machines to where we are now, and if we can keep up that kind of pace, then 10 years from today, no doubt we'll be in a good spot. So on behalf of everyone in the audience, I want to thank the panelists for a stimulating discussion. I want to thank the Royal Society for a really great day of panels. And with that, I will pass it back to our host for the day and the past president of the Royal Society, Chad Gaffield.
Thank you so much, Rob, and what a great session to close today. And thanks to all of you. Et rebonjour à tous et toutes, and I hope you all have enjoyed and benefited from this great day devoted to showing how, in fact, we can make a better future through robust digital health. It has been thrilling for me, as you can imagine, to see how the potential of the G7 Research Summit model has been so well realized today, thanks to the wonderful presentations and discussions throughout the day. Well, en guise de conclusion, and as a way of emphasizing our profound gratitude for all the insightful and compelling contributions, let me highlight 3 takeaways from our discussion today. One, I think speakers consistently emphasize the importance for the future of digital health of engagement and co-creation in pursuing digitally enabled, robust learning health systems. Such engagement and co-creation is essential to diverse research fields, and as was just pointed out, and in fact, across the public, private, and nonprofit sectors in Canada as elsewhere. And these sectors are all becoming so much more multifaceted in terms of their impact in the world of digital health. For example, the presentations today made me think of how over the decades we have learned on the one hand in the digital sector about the importance of user engagement or the user experience in developing digital tools. And then in health, on the other hand, we have learned the importance of patient-centered health systems. Well, in digital health, the speakers today have made clear that we need to embrace and integrate both approaches in an engagement and co-creation model for updating our policies and practices. For example, as was just pointed out, asking individuals to access multiple patient portals reflects old structures and undermines the ambition of enhanced digitally enabled health outcomes. All of this, as we've heard, is easier said than done. Great discussion throughout the day of principles and ethical frameworks that must guide this work, from safe people, safe data, Indigenous care framework, the fair data principles, and others. But clearly, in addition to such principles and ethical frameworks, we also must increase personal competencies in order to make digital health decisions. Digital literacy, for example, came up a lot today, and not just older generations. I think the myth that digital natives know everything about digital, we know that that's, we've been debunking that, and we've been finding that out, I think, in many cases. My sense is that our educational system has not prepared individuals to take advantage of digital health and, in fact, to make wise decisions. Another example is the importance of developing change management competencies. To make the physical to digital transformation will require inspired and informed work that must be taken seriously. Overall, I think the speakers highlighted the importance of trade-offs in reconciling overlapping and competing priorities. What is appropriate data privacy, given the potential for major health advances through data analysis, including AI? Speakers emphasized how successful learning health systems would be those that provide healthcare and stimulate innovation, better patient outcomes, and better health individually and collectively. But speakers pointed out that the pursuit of robust digital health faces a modern version of the historic tragedy of the commons, in which individual decisions unintentionally undermine the collective good and therefore are unwitting decisions that hurt the individuals making them. In Canada, since the development of the Tri-Council Policy of Research Ethics for projects that involve humans in the 1990s and subsequently, we've been learning a lot about how to implement engagement and co-creation models, but clearly digital health requires continued work to ensure we arrive at the best possible principled and ethical trade-offs as we take each step forward in digital health. Secondly, I think speakers emphasize the importance of recognizing the diversity of all those involved in digital health, from users, patients, but practitioners, all of us. This is so important given the increased attention to personalization, personalized shopping, personalized learning, and of course, personalized medicine. How to build digital health in a way that is inclusive and recognizes and embraces diversity across researchers, health providers, patients, and so on. This is so important since the promise of digital health brings together historically different knowledge systems, specializations, generations, and collectivities, all of whom engage with digital technologies in diverse ways. Clearly, the future of digital health depends upon such inclusion, as emphasized repeatedly today, and in fact, all this year, as we have faced the pandemic. We know from past experience that the hope years ago that digital tools would necessarily diminish inequities has been replaced by serious concern about the differential impact of digital technologies within societies. The fact that digital can exacerbate inequities and perhaps often does. Similarly, we know from past experience that contagious diseases, for example, can affect everyone, but they do so in different ways according to individual circumstances. As evident again this year, the usual pattern is greater negative impact on populations that are already vulnerable for other reasons, including poverty and prejudice. In response, I think speakers today have emphasized ways in which we must harness data and digital technologies to confront differentiation rather than increase inequity when replacing physical presence in health systems. Third and finally, what we've heard today emphasizes the importance of cautious optimism about the future of digital health. Despite many concerns that we've discussed, we heard about many examples of promising steps forward in implementing successful digital health. As we heard, there are important initiatives that we can begin scaling and to do so in ways that have widespread positive impact, including, for example, taking more advantage of smartphones and other mobile devices or experimenting with different financial models that are connected to health outcomes. And yes, we did end up implying the value of opening the Constitution to accelerate the making of digital health for Canadians. But how to do that obviously takes more than a one-day summit, and in fact, we may not need to do it at all. Now, as an historian, I recognize that my discipline is resistant to notions of progress, given the number of times that supposedly positive developments had destructive consequences in the longer run, sometimes completely unanticipated. Nonetheless, I think all of us, including historians like me, would probably choose to live now rather than any point in the past, and thus cautious optimism does seem to be a wise and justified way to think about digital health. And in fact, I think the overall conclusion of what we've heard today is that we can and indeed must build a better future through digital health. In closing, let me emphasize the RSC's profound thanks to our partners: University of Toronto, Fonds de Recherche du Québec, Canada Foundation for Innovation, the Natural Sciences and Engineering Research Council, l'Ambassade de France, the University of Calgary, and the Alex Trebek Forum at the University of Ottawa. And I must say, I think Alex Trebek would be very pleased with the value of the discussions today. Many thanks to all of you who have worked so hard on this event. I want to give special thanks to the organizing committee, led by the RSC International Secretary, Paul Young. And thank you so much, Dr. Young, our colleague, Paul. Thank all the speakers. What a terrific lineup of speakers today. Thank you so much to all the virtual delegates. I want to make one more point. And finally, as you know, this event has been made freely available to everyone and will continue to be available as an enduring contribution to trying to make a better future for digital health. But I'll be frank, this approach is not sustainable. As an independent, member-based nonprofit, the RSC needs greater financial support to increase operations to better fulfill the potential of scientific and scholarly contributions to global challenges like digital health. So there is a button on the RSC COVID Task Force page on the RSC site, and I encourage you to do all you can to support the RSC initiatives. In this spirit, the RSC is planning to continue focusing on urgent global challenges with G7 partners and others, and in the case of the G7, when the United Kingdom is host next year for our collaboration. More immediately, of course, the RSC's Celebration of Excellence and engagement activities are continuing this week, and we look forward to seeing you all again at the upcoming sessions. Special thanks to the wonderful RSC team at Walter House under the leadership of Darren Gilmore. Thanks again to all of you. Alors, merci encore. Bonne fin de journée et à la prochaine.
Thank you very much. Have a wonderful day and see you next time.